All right, well, recognizing that we're just about 1 minute past the hour, we have a robust agenda ahead of us. Would like to get started with today's CEPOP national webinar on combating the opioid epidemic through safe disposal strategies. I want to take a moment to just thank everybody who is on the line thus far for this webinar. My name is Matthew Rubin, and I work with the Collaborative for Effective Prescription Opioid Policies, or CEPOP. And again, just want to thank everybody for joining us today for this important public health and patient safety discussion. We're really pleased to see such a robust turnout for this really important and timely discussion, and I look forward to a productive discourse between our focus topic speakers for today's webinar and those on the line. Looking at the available evidence to support the use of at-home drug disposal to help augment existing options in removing unused and unwanted prescription drugs from the home, and subsequently mitigating risks for misuse, abuse, and diversion of these products. At the outset, would like to just have a few housekeeping items.
Backlit right now.
First, what we would like to do is to ask you to please mute your lines. We certainly want to be respectful of our presenters and avoid any unnecessary interruptions. Second, we do want to note that we are recording this webinar, and following today's event, we will be posting a copy of this presentation on the CEPOP website for future viewing and distribution. Of course, we encourage you to share this with your peers and your colleagues. Likewise, CEPOP welcomes additional thoughts and feedback from all of those on the phone today around areas of potential follow-up or engagement in which future national webinars may be focused. Of course, you may feel free to share that with me. At any point during today's webinar, please feel free to also engage with us on this. What we would really like to do here is to use the chat box to have an opportunity to encourage dialogue and to answer any questions that might arise during today's webinar. And so with this, what we would ask you to please do is, should there be any questions, put them into the chat box. And upon culmination of all of our focus topic speaker presentations today, we will have time for a facilitated question and answer. In the instance you are joining us via phone, you may feel free to email your questions to me directly at matthew.rubin@fagerybd.com. If you are on the line, you have probably seen the PDF one-pager for the event itself, and so you may just simply refer to that for my email address as well. So looking towards today's agenda, we're really pleased to have a robust set of stakeholders on the line today to discuss this important issue. As such, I will provide some very brief remarks, but saving the duration of our time here to focus on the presentations from our three speakers for today's call: General Arthur T. Dean from the Community Anti-Drug Coalitions of America, Dr. Tradd Brummett from the University of Michigan Medical School, and Dr. Jennifer Cooper from Nationwide Children's Hospital at the Ohio State University. And so really looking forward to hearing from each of these three individuals around some of their experiences around safe disposal of prescription drugs and ability to help influence our ability to remove unused and unwanted prescription drugs from the home. And so for those of you who might be unfamiliar with CEPOP or who are joining us and are not members of the collaborative, after today's call, of course, if you are not, please feel free to reach out. Happy to provide additional information on the collaborative. But the Collaborative for Effective Prescription Opioid Policies was founded about 5 years ago and convened initially by Trust for America's Health, CADCA, from whom you'll hear from later today, as well as the Honorable Mary Bono in October of 2014, around the need and desire to develop a comprehensive and coordinated response to the prescription opioid epidemic. And to date, we're really pleased to have such significant buy-in from more than 85 national organizations that represent all facets of the public and private sectors, from patients and healthcare providers throughout the duration and entirety of the pharmaceutical supply chain and healthcare delivery system. And so as part of CEPOP, there are 3 working groups that are currently stood up and engaged on many of the different issues that are of core policy priority for the organization. We have the Prevention Working Group, Safe Use Working Group, and Safe Disposal and Anti-Diversion Working Group. And as you can likely guess, the Safe Disposal and Anti-Diversion Working Group is a leader in the organization's efforts to promote safe disposal strategies. And so would want to certainly take a moment to thank the working group co-chairs Judy Lund-Person and Brad Tallamy of the National Hospice and Palliative Care Organization and AmerisourceBergen, respectively, for their leadership in this and helping to drive the working group's agenda around safe disposal and efforts to help ensure that this component of the opioid epidemic, that this could be a viable option to help mitigate some of those risks. And so just with that brief overview, I'm really pleased to turn the call over now to one of CEPOP's co-conveners and a national leader in the fight against opioid epidemic, General Arthur Dean from the Community Anti-Drug Coalitions of America, or CADCA. General Dean has served in his role as chairman and CEO of CADCA since August of 1998 and is responsible for helping to provide strategic direction and leadership for the organization and its community coalitions nationwide. Before joining CADCA, General Dean spent more than 30 years in the U.S. Army, retiring in August of '98 at the grade of Major General. During his time in the Army, General Dean served around the world, seeing combat in the Republic of Vietnam and Saudi Arabia. He was a U.S. Army and Republic of Vietnam senior parachutist and an Army Ranger. So he certainly has done it all, and now we're very, very pleased to have him helping us address some of the issues around the opioid epidemic and have his leadership both within CADCA as well as now with CEPOP. And so we're thrilled to have General Dean join us this afternoon, and I'm pleased to turn the call over to him for a few remarks around CADCA's efforts to promote safe disposal across the country. General Dean?
Matt, thank you very much for that introduction and for leading this very, very important webinar on combating the national opioid epidemic through safe disposal strategies. We at CADCA has been very pleased to be a part of CEPOP from the very beginning and working with so many partners to solve this issue. What I want to do is quickly give a little national overview, talk a little bit about CADCA, the organization that I'm fortunate enough to serve as the chairman and CEO, and then talk more specifically about things that we've been doing across America to address this issue. But the National Survey on Drug Use and Health, it's called NSDUH, NSDUH, reports that there are some 20.3 million American adults aged 12 and older that battle a substance use disorder in 2018. According to NIDA, the National Institute on Drug Abuse, alcohol, tobacco, and illicit drugs cost more than $750 billion annually in crime, lost work, and productivity and health care to our economy, $740 billion. Also, according to NSDUH, there are 50.5% of those who misuse prescription pain relievers in the past year said they obtained those prescription pain relievers that they had most recently misused from a friend, a relative, or friend. And this number varies anywhere from 50% to 55%, depending on which organization you are receiving your information. The bottom line is that more than half of those using these medicines gets them from friends and families. Provisional data from the CDC predicts that the total number of drug overdose to be found this year may be down a little bit. We think that number will be about 69,100 in 2018. And as you know, it was over 70,000 in 2017. So the first decline, not a major decline, but the first decline that we've seen in decades. CADCA believes that preventing substance misuse before it starts is the most effective and cost-efficient way to reduce substance misuse and its associated costs. So we strongly believe that. The national opioid epidemic is going to take all of us, all sectors in the community working together, and clearly there's a role for primary prevention along this continuum if we're going to be successful. A little quick information about the organization. We were founded in 1992 as a result of a Presidential Drug Advisory Council. There was an epidemic then. It was cocaine. CATCA represents now more than 5,000 communities nationally, and we've worked in more than 30 countries internationally, and we built over about 500 international coalitions as well. Our mission is the same as it was back in 1992, to strengthen the capacity of community coalitions to create and maintain safe, healthy, and drug-free communities. We do that now globally. We do all the kinds of things that most associations would do. We have a robust public policy and advocacy team here, and we work diligently to make sure appropriate laws are passed and money is appropriated. We do a lot of training. We'll talk more about that. Research and evaluation, particularly on the dissemination of research out to our field. We host large training events, lots of communications, a lot of international work to include with the United Nations. We've been certified by them. We care dearly about our youth, and we have a lot of youth programs and trainings. We are a membership organization, and we believe in strategic alliances. Each year, we host 2 large training events, one called our National Leadership Forum, one called the Mid-Year Training Institute. The Leadership Forum is always in Washington. We consider Washington to be corporate headquarters because of our access to federal leaders, political leaders, and that's critical. That has grown to over 3,000. All federal agencies, political types are involved in that, and we spend an afternoon on Capitol Hill. The 30th one will be held February 3rd through the 6th at the Gaylord National here just outside of Washington, D.C. In the summer, we have a mid-year training institute. We'll be having, I think, our 22nd one of that come July. It will be July 26th to the 30th in Nashville at the Gaylord Opryland. There we have in-depth courses that typically are half a day in length. We have over 2,000 individuals there, and generally more than 100 international attendees as well. So we do a lot of training. Quickly, a coalition is a formal arrangement for cooperation and collaboration between groups and sectors of a community to work in a strategic way using evidence-based strategies to build a safe, healthy, and drug-free community. Each of those groups retain their individual identity but are all agreed to work together. The coalition brings together all these sectors with the goal to reduce the use of and misuse of substances at the population level using environmental strategies. Some of the things that we have done in this space specifically, we started work in 2015. CATCA has been involved in distributing drug deactivation pouches across the country. We first partnered with Mellencrot in Florida in 2015 for a pilot project trying to assess, engage community interest in using the safe disposal strategies and pouches as a way to reduce homes and their communities of unwanted and unused medicines. Given the positive reaction and the impact of distributing 40,000 bags back then in Florida, CATCA and Mellencrot held a disposable pouch distribution event in Washington, D.C., where we distributed 100,000 pouches as well. Following these 2 successful initiatives, Katka and Melon Crowd also worked together to distribute deterror pouches in Indiana and West Virginia, and they met with great success as well. We have partnered with our friends Leidos to promote the use and safe disposal pouch strategy. We held an event with them at Aberdeen Proving Ground, an Army installation in Aberdeen, Maryland, and we were fortunate enough with our partners at Leidos to distribute 100,000 pouches, and we used our coalitions to distribute them, and they met with great success. In 2018, CACTO partnered with the RX Abuse Leadership Initiative Rally. We were one of the original national partners of Rally, and our first community event was held with the state of Maryland. The RX Abuse Leadership Initiative Rally is a convening organization of community and advocate leaders working to address our nation's opioid crisis, and it's a broad array of partners, as you can imagine, all coming together to work this problem, and Rally has been very, very successful in helping us do just that. This partnership represents prevention and the addiction communities, and to date, we've been fortunate enough to work with Rally in 14 states. And through this partnership, we use CATCA community coalitions to distribute the deterror disposal pouches, and we normally distribute or give to each of the communities that we go into a state 50,000 of these, obviously free. And our Rally partnership has caused us to distribute more than 700,000 of these deterror pouches. And in total, working with all of our partners, we have distributed more than 1 million of these pouches. These deterror disposable deactivation systems have meant a lot to us, to our community coalitions. The reports that we receive is that they are an effective strategy to help the individual homes as well as the communities to rid themselves of unwanted and unused medicines. And as a result of that, we've seen a reduction in the misuse of these medicines and lives saved. So it's been a great success, a wonderful strategy, and we have enjoyed the many partners that have allowed us to bring to our communities across the United States, particularly in these 14 Rally states, more than 1 million of these pouches. I look forward to our discussion and questions at the end, and thank you for the opportunity to share with you this afternoon.
Thank you so much, General Dean, for those remarks, and appreciate once again your leadership in this very important component of our national response to the opioid epidemic. We're now pleased to turn the focus of our call over towards the more clinical perspectives associated with at-home drug deactivation and disposal, and some of the evidence to support its use as a viable tool to help us improve our efforts to remove unused and unwanted prescription drugs from the home throughout the country. We'll first hear from Dr. Chad Brummett from the University of Michigan around some research that he has recently published in JAMA Surgery, along with other colleagues, around improved disposal rates for patients provided at-home disposal tools, followed by some remarks from the Ohio State University's Dr. Jennifer Cooper, and findings that she and colleagues have published in JAMA Pediatrics regarding their unique research into a patient subset within pediatrics. We ask, again, as a reminder, that you please hold any questions towards the end of the webinar, when we'll have a dedicated time for a facilitated Q&A with our speakers. At any point during the webinar, please feel free to enter the questions into the WebEx chat box. We'll continue to track these questions throughout and work to get them all answered upon the culmination of both of our presentations. Of course, we ask that in the instances you are not, to please mute your lines once again, just so that we can be of utmost respect for Drs. Brummett and Cooper and avoid any interruption in their remarks. And so with that, Dr. Brummett is an associate professor at the University of Michigan, where he's the director of pain research and more broadly, the director of clinical anesthesia research. He has well over 140 publications, including articles in top journals such as JAMA, JAMA Surgery, Anesthesiology, Annals of Surgery. He is the co-director of the Michigan Opioid Prescribing Engagement Network, or Michigan Open, which aims to apply a preventative approach to the U.S. opioid epidemic through appropriate prescribing after surgery, dentistry, and emergency medicine. In addition, his research interests include predictors of acute and chronic post-surgical pain and failure to derive benefit for interventions, for other interventions and surgeries primarily performed to treat pain. He is the co-PI of 3 major NIH grants studying these concepts and also receives funding from the Michigan Department of Health and Human Services, SAMHSA, and the CDC. Dr. Brummett received his medical degree from the Indiana University School of Medicine, followed by residency and fellowship at the University of Michigan Health System and Johns Hopkins Hospital, respectively. We're thrilled to have Dr. Brummett join us today. And with that, pleased to then turn the call over to him to provide some additional remarks.
Great. Thanks, Matt. Appreciate it. And am I able to advance okay? Do I need to do something to be able to advance the slides, Matt?
I am just working now to make you a...
Sure. Great. Well, while they're doing that, I'll go ahead. While you're doing that, I'll go ahead and get started. So I'm Chad Brummett. As you said, I'm the director of the Michigan Opioid Prescribing Engagement Network, and I will show bipartisan support for the opioid epidemic because when you have Michigan and the so Matt, do you want me to present these from my? Is this?
Sure. Please go ahead.
Okay, great. So this shows bipartisan support because we have Dr. Cooper from Ohio State and I'm here from the University of Michigan, and we are working together, and we are actually truly working together. So while I'm not an author on their subsequent work, some of that work actually was in a collaboration with the University of Michigan, which I think is great. So I think I'll put it in context for what we do. We really focus on surgery, dentistry, and emergency medicine, and we actually know, and these are data from the Dartmouth group, who really Hill and Barth were the first to really describe this concept and this problem. This is something that previously really had not been recognized, which was that the majority of the pills that we write to people after acute care, and specifically surgery, dentistry, and emergency medicine, go unused. I'm not talking about chronic opioid use. When I'm a pain physician, I do manage patients with opioids. While I believe that there's a way to tighten up our opioid use, I believe they have a role in acute pain, and I do manage some of my chronic pain patients with them. Matt, am I okay to advance now?
Yes. So I actually, your slides were not showing up, so if it's easiest, I might just run them from here.
That's great. Yep, that's fine. But, 72% of the pills going unused. So if you go next slide. And so if I put that in context just for our state, we do about 1.8 million surgeries per year just in the state of Michigan. This is just surgery. And 45 pills was just an amazingly consistent average as we went across the state, which would mean about 33 pills in excess per surgery. Next slide. So this would be 62 million unused pills. And if you click, this is what it would look like if we laid this out in advance of the Michigan-Ohio State game. This is what our 1 year's unused pills from prescribing just for surgery would look like. So the context here and the importance here is to understand that we have billions of unused pills in our community. And while I won't talk about it today per se, the opioid disposal and ridding our medicine cabinets of these unused pills is a big part of the Michigan Open work. And we hold pill drives. Our last pill drive was in 96 cities. We got about 3,400 pounds of pills out of our communities in just a 4-hour period. We're proud of that work, but we realize that that's not going to do it. Next slide. Oh, you can click through. We'd also need part of our hockey arena. Next one. So why dispose? Well, I think it's important to put this into context, and if we think about it from a risk, there's young kids. We talk a lot about people intentionally misusing or kids experimenting with opioids. But right now, and this is all substances, but about every 10 minutes you have a kid visit the ER from an accidental medication poisoning. And the reality is that when you talk to patients or people in your community, after they get these pills, they just put them in a medicine cabinet and forget about them, and they oftentimes aren't always in the safest places. But I think where most of our focus as it relates to opioid misuse and abuse, and General Dean did a great job of kind of setting that context, is that what's driving the opioid epidemic today is largely heroin and fentanyl overdoses, but this is still, at its core, a prescribing epidemic. And I run counter to that growing narrative that this is no longer a prescribing epidemic, because if you look at most of the people who, or when we ask most of the people who develop opioid use disorder, they start with prescription pills. So most of the people who use heroin start with a pill as their first exposure. Maybe not a pill prescribed to them, but as a physician, I always say that I believe that I'm part of the opioid epidemic, that I helped directly contribute to the opioid epidemic, maybe not intentionally, but that I am responsible for everything I prescribe, whether to that patient or wherever those pills go. And when we think about where they go, next slide, and click again, that this was already mentioned, but this is among kids 12 and older. 12 and older who admitted to misusing or abusing an opioid, more than half of them got them from a friend or family member. And this is very easy. And this was an important moment for me. I was at a local high school giving a talk to 100 juniors and seniors and said, how many of you could go home and within an hour access an opioid? This was a couple of years ago, and 3/4 of the kids immediately raised their hand. And while I'm not saying that 3/4 of the kids were misusing or abusing opioids, they've processed it, they've talked about it, they've thought about it. There's about 17% that have them left over from their own care, and really drug dealers are a small part of this. And I can't help bring it back to stories, and I work some with the 525 Foundation in South Bend, Indiana, Becky Savage, who lost 2 of her 4 boys in one night to what really comes down to unused pills. There were unused pills at a party, and by all accounts, this is probably their kid's first time experimenting with opioids, but obviously had a devastating outcome for that family and it forever changed that family. And so these excess pills matter. Next slide. And so we've made materials. I would strongly encourage those organizations out there that are interested to go to our website, which you'll see at the end. We have freely available materials, and we actually we go a step further. We allow you to brand those materials. And what do I mean by that is once you put in your information and you put in your logo of your practice or your health system or whatever logo you want there, we'll actually put it on top of this just so you have some additional information. And here's an example of a poster that we hope that people can put up on their the walls of their offices to help just to start to generate a conversation about safe disposal. Next slide. So beyond safe disposal, we also need to think about storage. Well, what opioids are prescribed, even if it's only for a transient period of time, storage is really important. We have, high-level storage options, which are like safes and other things, but, it's regardless, it's critical that you keep them out of easy access spots. And we do encourage pill counts. There's obviously technologies that are being brought forth about pill dispensers and locked caps, and I think those are all interesting, but in the end, personal responsibility is probably the most important and lowest hanging fruit, and it's free. It just needs some education. And then with disposal, I think we need to remind people why. This gives the take-back slide for our state, where we've actually called and ensured that every single disposal site actually takes opioids, because sadly, a lot of what's on the DEA website is not accurate. This is a well-intended pharmacy who registers, but then doesn't create a process. And you can imagine now as a patient, you bring these back to that pharmacy for the first time. You actually took the inertia, you got it all together, and then you're denied the ability to dispose of your opioids. They're probably going to go back in a medicine cabinet and never come out again. But there are take-back drives, and then, we really are not big fans of household trash. We definitely are never flush people. We are believers that this FDA statement that you should flush your pills is a really bad statement. We now know that we have detectable levels of oxycodone in the oysters off the Puget Sound, and I think it's really time that we stop flooding our waterways with unused pills, but there are potential other ways to do household trash. And so getting more to the topic of today, next slide. This is the very simple final figure from our RCT that we published in JAMA Surgery this year. Basically, we took people from an outpatient surgery center. It was about 400 or 500 patients. We randomized them to either get a couple weeks of usual care, which means that The nurses just said whatever they wanted about disposal. We called people later and asked them whether or not they disposed of their unused pills. You see that our usual care disposal rate is probably about 3 times the national average. The reason for that is Michigan Open's done a lot of work in the surgery center, and we've probably tainted the water a bit. We compared that to an information sheet that gave a very detailed report on how to find and locate disposal areas in your community. And while maybe a little bit higher, not statistically significant, that was a little disappointing. And then on other days, we randomized patients to getting the Deterra drug bag. Now, we've talked a lot about Deterra today. There are other companies out there. I have no specific ties or affiliations with Deterra. We just grabbed their bag. I do think that they are within a cost in a cost realm that could be integrated into clinical care. But as you can see, just getting that Deterra bag without a whole lot of it was not a detailed intervention. We put a simple card on top that explained what the bag was and why we were giving it to them, and there was no other specific instruction given. And as you can see, it had a major increase. And so we can only imagine that if we were to do a more detailed intervention, trying to really think about how and when we give that bag, it would be even better. Next slide. And so I show this. This is our website. This is where you would go to get our materials. There's also materials in there about teaching people how to safely use, store, and dispose of opioids during surgery, dentistry. They're available in Spanish and Arabic. They're colorful. They are engaging. And then we have some disposal information there as well. Next slide. And that is where you can find more information, michigan-open.org. Thank you.
Thank you so much for your remarks, Dr. Brummett. I really appreciate it, and you leaning in a little bit more around some of the issues that you identified through your research and ability to engage with your colleagues at the University of Michigan. Next, we'll turn the call over to our second clinical provider for today, Dr. Jennifer Cooper. Dr. Cooper is an assistant professor of pediatrics and epidemiology at The Ohio State University and a principal investigator in the Center for Innovation in Pediatric Practice and Center for Surgical Outcomes Research at the Abigail Wexner Research Institute at Nationwide Children's Hospital. She's an epidemiologist, biostatistician, and health services researcher whose research involves the use of large clinical administrative databases, the design and analysis of clinical trials, and prospective observational studies, and the development of novel methods in statistics and data science. She studies healthcare access and outcomes in children and young adults with surgical diseases and injuries, and works to design multi-level interventions to improve healthcare access and outcomes in the population. She has more than 100 publications, including articles in top journals such as JAMA Surgery, JAMA Pediatrics, and Pediatrics. She currently serves as a PI or co-investigator on projects funded by NIH, PCORI, and several other foundations. Dr. Cooper received her Master of Science in Chemical Engineering practice from MIT, her Master of Science in Biostatistics, and a PhD in Epidemiology from the University of Pittsburgh. Thank you to Dr. Cooper for joining us today, and we look forward to your remarks. Happy to turn it over to you now.
Great, thank you. Thank you for the kind introduction. You can move to the next slide. So this work, just to be disclosing where it was funded by the Ohio State University Opioid Innovation Fund, as well as a grant from the National Center for Advancing Translational Sciences to our Clinical and Translational Sciences Institute at Ohio State and Nationwide Children's Hospital. And I don't have any other disclosures beyond that. Next slide. So opioids are certainly an important component of pain management in children who are recovering from severe injuries or surgery. But certainly these medications, as we've seen across the country, are prescribed in excess and rarely disposed of appropriately, unfortunately. And a number of studies have shown that in both adults and children, less than 30% of surgical patients actually dispose of their excess opioids after surgery. In the pediatric population in particular, as Dr. Brummett mentioned, this lack of prompt and proper opioid disposal places young children at risk of accidental ingestion and also enables diversion by older children, family members, and friends of these medications for non-medical use. Now, as was mentioned, the US FDA does currently recommend utilizing take-back options for disposal of unused or expired opioids, but they do recommend that if take-back options are inaccessible, that flushing be used. Take-back options such as drug take-back days and drug disposal boxes at authorized pharmacies and law enforcement agencies certainly can be inconvenient for many families, however, and some families may also have some concerns as well about the environmental effects of flushing. Next slide. Certainly one means by which opioid disposal might be improved is through patient and family education. And several studies have, in fact, targeted the problem of non-disposal of excess postoperative opioids by providing educational materials that describe recommended methods for safe disposal to adult surgical patients. However, these studies, unfortunately, have had mixed results, and this is likely due to the inconvenience of disposal and also the desire of some patients to retain their opioids for fear of future pain. Next slide. An alternative to take-back options, as we've discussed, and an alternative also to flushing as well, is the use of drug disposal products for in-home disposal. And the doTERRA drug disposal bag is one such product. It contains, as Dr. Brummett mentioned, just a small pouch of activated charcoal. When water is added to the bag, the activated charcoal is released, absorbing medication that's placed in the bag. The entire bag can then be disposed of in the home garbage. As General Arthur mentioned, a number of organizations, governmental and otherwise, as well as health systems and pharmacy chains, have begun to distribute these bags or similar products to patients and community members. However, when we were planning our research in the area, the evidence was really not clear as to whether providing these bags to pediatric surgical patients would actually increase proper postoperative opioid disposal. Next slide. Therefore, we decided to perform a randomized controlled trial in families of pediatric surgical patients to answer this very question. And you can click a few more times just to show the materials that are provided at our institution. So in our trial, we included parents and legal guardians if they had a child aged 1 to 17 who was having outpatient otolaryngologic or urologic surgery and was expected to be prescribed an opioid. Participants were randomized either to standard education by the care team or to standard education plus the receipt of the drug disposal bag. Now, at our institution, standard education consists of a handout called Important Facts to Know About Opioids, as well as a video, and these describe proper opioid use, storage, and disposal, but these materials make no mention of drug disposal products for in-home disposal. So the intervention group in our study additionally received a drug disposal bag, and the instructions on the bag describing its proper use were reviewed with the family by a research assistant. Next slide. So 210 families approached about participating in our trial. 202 actually agreed to participate, 103 of whom received a drug disposal bag and 99 of whom received standard care. And the vast majority completed a follow-up survey at 2 to 4 weeks post-op, and all of these participants were included in our primary attention to treat analyses. A handful of participants, 21, were lost to follow-up either because their child was not prescribed an opioid or because they failed to complete a follow-up survey. And then an additional 27 participants were excluded from our per-protocol analyses because they either chose not to fill their child's prescription or their child had no opioids left over after their pain had resolved after surgery. Next slide. This table just shows some key characteristics of our study population, the included caregivers and patients in our study. Most patients in our trial were young children who underwent tonsillectomy, one of the most common surgeries performed in kids. Most were prescribed hydrocodone in liquid formulation because they were young kids. About 15% of included households actually had someone living there who had chronic pain, and about 5% had someone living there who was currently using prescribed opioids. Next slide, please. This table shows the results of our trial. In our primary intention to treat analyses, which included everyone, whether they had any leftover opioids or not, we found that over 71% of participants in the intervention group and 56.2% of participants in the standard care group, as shown on the first row, actually reported properly disposing of their child's leftover opioids. And proper opioid disposal was defined in this trial as either use of an FDA-recommended method or the disposal bag provided. This difference was similar when disposal by any method was considered, even those that weren't recommended. A slightly lower percentage of families who received a drug disposal bag actually filled their child's opioid prescription, however. There was no difference between groups in the proportion of families that had opioids left over after their child's postoperative pain had resolved. Among parents reporting proper postoperative opioid disposal, the majority who didn't receive a disposal bag actually just simply poured the leftover opioids in the toilet or sink, whereas the majority of those receiving a disposal bag did use the bag for opioid disposal. And very few families actually disposed of their child's opioids by using take-back options, with no families who received a disposal bag doing so, and less than 20% of families who didn't receive a drug disposal bag actually doing so. And then lastly, about 11% of the parents or guardians who received a drug disposal bag actually reported using the bag to dispose of other medications that were either left over or expired and just were in the home. And then finally, in our per protocol analyses, which included only the caregivers who filled their child's opioid prescription and whose child actually had leftover opioids, we found that differences in rates of opioid disposal between groups were very similar to those that we found in the primary analysis. One unanticipated finding from this study was the significantly lower rate of opioid prescription filling among families who received a drug disposal bag. If you could go back to the previous slide, if that would be okay. So this finding actually might indicate that simply providing a drug disposal bag and discussing it immediately after surgery may emphasize the dangers of opioid use to some families, leading them to perhaps fear the risks of opioids enough to forgo filling their child's prescription. This only happened in a few families, but it's also important to note that this decreased prescription fill rate did not translate into less adequate pain control in that group, though I didn't show those data. And then finally, although our trial clearly demonstrated that drug disposal bag provision increases proper opioid disposal among families of pediatric surgical patients, the generalizability of our findings is somewhat limited by the fact that we studied only outpatient surgical patients, and most patients in our trial were young. You can actually go to the next slide now. Sorry about that. So just some of the key limitations of this trial were that the vast majority of kids were young. 97% received liquid opioids, which many adults, based on surveys that we've done, may consider these liquid opioids to be less potent or amenable to misuse. It's also well known that adolescents and young adults are at a much higher risk for opioid misuse than young children. Next slide, please. So in a subsequent study, we evaluated the impact of drug disposal bag provision on opioid disposal among all children who were dispensed opioids at our institution's outpatient pharmacies. And in the second study, we included all parents and guardians filling an opioid prescription for their child, as well as young adult patients filling their own opioid prescriptions. During the first 6 weeks of participant enrollment, only standard education was provided to families by pharmacy staff. And during the second 6 weeks, a drug disposal bag was provided and instructions for its use also discussed. A follow-up survey to assess opioid use and disposal was then completed 4 to 7 weeks later. Next slide, please. This table shows some key characteristics of the participants that were included in our second study. Most participants were parents or guardians again. However, the average patient age in this study was a bit older at 11 years, and about half of the patients included were prescribed pills. Most patients, again, were dispensed opioids for pain following surgery or another invasive procedure, which is what you would expect in a pediatric population. Next slide. This table shows the results of our second opioid disposal study. Just as in our randomized trial, there was no difference between groups in the proportion of families that had opioids left over after their child's pain had resolved. But among families who did have leftover opioids, again, over 71% of those who received a drug disposal bag reported disposing of their child's leftover opioids, whereas only about 50% of those who didn't receive a drug disposal bag reported disposal. Among those families reporting disposal, the majority not receiving a disposal bag, again, simply poured the leftover opioids in the toilet or sink, whereas the majority of those who received a drug disposal bag did use that bag, again, to dispose of their leftover opioids. And again, few families disposed of their child's opioids by using take-back options. About 12% of the families included who received a drug disposal bag used the bag to dispose of other leftover or expired medications in the home. And next slide, please. So overall, in conclusion, first, in comparison to adults, the published data on adults, pediatric patients really do seem to be more likely to either dispose of their excess opioids or to have them disposed of on their behalf by a family member in comparison to adult surgical patients and adult patients in general. And second, providing a drug disposal bag to the caregivers of children prescribed opioids certainly does increase significantly the likelihood of opioid disposal. And this seems to be the case both among younger children and older children as well. And finally, our findings suggest that greater availability of drug disposal products can certainly complement prescribing reduction efforts that are ongoing in the fight to reduce the opioid epidemic and opioid misuse in this country. So I just thank you for your attention. I'd be happy to answer any questions later by email as well as on the call today.
Wonderful. Thank you so much for your remarks, Dr. Cooper. Greatly appreciate you walking through some of the findings that you've been able to uncover. And with that, what we'd really like to do now is to spend about 10 minutes or so with facilitating a Q&A between those on the webinar as well as our presenters. As noted earlier, we ask that should you have any questions, we ask that you please submit them within the chat box for the WebEx, or please feel free to email them to Matthew Rubin, myself at matthew.rubin@favorybd.com. But with that, one thing, I guess, sort of echoing back to some of the remarks from General Dean. General Dean, I was wondering if you would be able to speak a little bit now about any feedback that CADCA has received from individuals who have received some of the disposal pouches regarding their usefulness or ability to actually help rid of unused and unwanted drugs from the home.
Thank you very much, Matt, and thanks to our other speakers as well. They did a great job. We have received tremendous feedback from our coalitions. As I said earlier, we worked in the state of Florida with 4 coalitions. We then came to D.C., been over in Maryland, and we've been now to 14 different states with RALLY, the RX Drug Abuse Leadership Initiative. What our coalitions are telling us is that they can't get enough of these disposable pouches to share with members of their community, that their use is unbelievably well. People really want them. They are, in fact, using them to dispose of the medicines properly. The challenge that we have is trying to find additional resources to provide additional pouches to our partners. We even have included just all of the sectors, but I want to speak specifically about one. I was just recently in Las Vegas speaking to the realtors, and they have taken this on as a strategy to help their salespeople, because they've had some incidents where salespeople have been actually hurt through people breaking into homes that are on the market at an open house to raid the medicine cabinets. So the realtors are, in fact, a partner now as well. So the bottom line is, yes, we've had great feedback. They have been widely accepted and used in our communities. What CADCA is trying to do now is scale that and find even more. And as you heard from the doctor, 1 million bags that we've given out is just really getting started. The problem is huge.
Thank you, General Dean. And to follow up, we did get a question from Adam Kuykendall, and perhaps this goes to you, General Dean, but also to both Drs. Brumman and Cooper. Do you have any advice for county coalitions on how to engage healthcare systems in providing in-home disposal options to patients?
I'll let the doctor go first, and I'll follow up.
Yeah, I mean, I think we're seeing increased interest. There are health systems that are taking this up. I think providing information to health systems and sort of sharing the data, and Dr. Cooper and I have both shared. I think now we're showing high-level data. This is no longer just anecdote or opinion. We're showing randomized control trials within healthcare showing that they work and that they increase disposal. And you really don't have to sell the importance of disposal. I think the challenge becomes, and where we still have gaps, is who's going to pay for them. While it may only be $2 or $3 a bag, and the price varies. I'm guessing that someone from Deterra is on right now, but I think there's probably some variance in the pricing. In the healthcare systems where we're constantly squeezing the orange, I think trying to figure out who's going to pay for them is important, and still a gap. I think education is probably the biggest and most important start point, and then each health system is probably going to take this on a different way.
Yeah, I would agree with that as well. Here at our institution, we've been fortunate to receive some funds from the Opioid Innovation Fund that I mentioned at Ohio State to cover these bags for a number of months. And we're continuing to work with the state, as lawsuits get settled and additional monies become available through public health agencies and otherwise. It doesn't necessarily have to be the health system. You could work with your government sort of connections that your health system may have with your state government or local government or even federal government to find funds that might be available as well.
And I thought a really important point that Dr. Cooper made that I think is something we had talked a lot about. We didn't measure it, but we actually, thankfully, I think, talked to you before you started your trial. The giving people the option to use that bag or additional bags for the many pills they know they have in their home is an opportunity. So surgery and acute care represents a touch point, and the point where you have somebody's attention. We get lulled into aspects of primary care where it becomes more routine, but people really pay attention during surgery and these bigger care episodes. And so they can be a touch point. We've used them for years to get people to stop smoking. This could be an opportunity to say, hey, look, you might be a person who needs 10 bags, or you might need one of the bigger bags. They have other larger bags because we want you to actually go through your medicine cabinet. We're going to make it easy for you. Or here are all the places in your community where you can take your pills in and use it as that intervention. I still think the in-home is the easiest, but we do have more and more pharmacy chains now making things available, because while I applaud law enforcement for making opioid disposal available, for many people walking into a law enforcement office with opioids does not feel good and it does not feel safe, and so it's not really accessible to sizable portions of our country.
The only thing I would add that we now have the data as described by Dr. Berman and Dr. Cooper that we can use to take to the local county medical advisors, take to the states as well. And CATCA has been working with the states because they received all these dollars to address the opioid crisis. And we're asking them to not only use them in treatment, but also to use them in prevention. And we see that safe disposal is an effective strategy, and a few of the states have stepped up. So at all levels, we should be using this research to help us carry the day and have them using, we believe, in an even more efficient way, the billions of dollars that the federal government has passed out to the states to address the opioid crisis. Disposal pouches is one way to do that.
Wonderful. Thank you so much, General Dean, and to Drs. Brumman and Cooper for that. And thank you to all that are responding with our offer to solicit questions. We are getting a ton of questions here, so we're going to do our best to answer all of them in a timely fashion in the next 5 minutes or so. But I guess the next question we have here would be for Drs. Brumman and Cooper, in that it seems like a major challenge in increasing safe at-home disposal involves changing human behavior. Both your studies show that an at-home option can help do that compared to, for example, take-back bins or other available options. Given how the U.S. healthcare system works, what do you think could help continue to drive the availability of this and to continue to help build out on our ability to convey potential risks and available options to patients and caregivers?
I guess I'll take that one.
Go ahead.
Okay. I think the two key components at our institution have been changing provider behavior, and then, as was mentioned by the questioner, changing patient and caregiver and family behavior. And I think changing provider behavior, by that I just mean really making education about opioid use, storage, and disposal a standard part of the education provided by the care team, that every patient coming through the surgery center or coming off the floor after surgery and being discharged home really receives in a consistent way. And we've been able to really make that consistent over time at our institution. And I think that's why our rate of disposal of opioids after surgery was so high, even in the control arm of our study. And then also changing family behavior and knowledge about opioid use, storage, and disposal, again, is really driven by education. But also, as we saw in our trial, just the supply of a free, easy to use bag at home to dispose of opioids was really something that families found to be very useful, whether that's because it was so convenient or because it really actually served as just a physical reminder of the need to dispose of their unused opioids as well, probably some combination thereof. But I think, by working again with local governments, state governments that have a lot of additional funds now to target to reduce opioid misuse, I think by education and the use of these simple tools, really, it can make a big difference.
Yeah, and I would agree. I think this is part of care pathways. I think when you're talking about care pathways, they're best put into people who do things in a routine fashion. So nurses, even thinking about our discharge planners and engaging them in care, because I think sometimes we underestimate what people can do, because this is something that an educated layperson can teach, especially with the right materials. And our patient materials actually go through and give the proper education. And so I think that becomes an opportunity. I think we still have a major unmet need in our communities to really, there's a lot of awareness of the opioid epidemic, but there's a lot of stigma and a lot of misconceptions, people viewing junkies and using a lot of stigmatizing language and assuming this can't be me until it's you or a family member. And I think the reality is we know that this has spared no part of our society. Every single community has been affected by this, and maybe the reason it gets more attention than other epidemics in the past, which may or may not be appropriate, but the point is this: it's affecting everybody, and we still need this public-facing campaign to just make people aware and appreciative of this. Matt, I would like to comment just for a second. I got a note here from someone from the FDA, and I guess I'd say this: if flushing becomes the only option, and it is a person's only option, I am aware and appreciative of the fact that flushing is better than not disposing. However, I think what we're showing through this and other efforts is there are many, many good options, and whether those levels of oxycodone in the oysters and Puget Sound are detectable or not, they are detectable. Whether they go above a threshold or not is less important to me. The Environmental Protection Agency does not recommend flushing. There's the Canadian standard is to not flush. I think the FDA is an outlier here and really needs to reconsider its position. That's my opinion. And that's also buoyed by some environmentalists here at the University of Michigan who have also looked into this work. So I'm sorry to be provocative, but I think these are forums through which we should have hard conversations. And I'd be happy to talk about it more with the FDA.
Thank you, Dr. Brummett. And sort of with that, to follow up, have you had that opportunity to share your data? And I guess this also goes to Dr. Cooper as well. But being able to actually share that data with federal agency partners, be it FDA, DEA, CMS, SAMHSA, or others, to help demonstrate the effectiveness of these interventions to help augment our current opportunities and options for at-home drug disposal?
I spoke at the analgesic division of the FDA about acute care prescribing broadly, and we touched on disposal. We sort of talked about the full Michigan Open Platform because this is just one relatively small portion of our overall platform. But yes, I have spoken to the FDA. We have not gotten into the specifics of the TerraBag or otherwise. And I got to be careful again. We're doing a pretty good advertisement for doTERRA in here. There are many other activated charcoal products out there, and so my point is this: this is one option, and these options are viable, really meaningful options that we should be looking at more broadly. And I just simply credit doTERRA for being one of the first to kind of make it go, but I don't specifically endorse doTERRA over another project. Like I think there's Dispose RX. I don't usually like to use a branded product like this so much in a talk like this.
I have not had the pleasure of discussing our findings. They're a little bit more recent than Dr. Brummett's with the FDA. We've published them in JAMA Pediatrics, as was mentioned, and I've discussed them at several meetings with surgeons and other providers, as well as with some folks from state government here in Ohio. But no, I haven't actually interacted with federal agencies regarding them.
Thank you both. And I know we're coming up on the hour now, and we do have time for one last question, and perhaps this goes for all three of our speakers as we look to wrap up. But just speaking a little bit around individual responsibility around drug stewardship, really until now there hasn't been a lot of education on this topic. But sort of as we look to wrap up this webinar, are there any suggestions, thoughts, or opportunities to go forward to help raise this issue?
Yeah, so I guess what I would say is that as a physician who prescribes, I feel responsible for all the pills I prescribe. And I feel like we need all of our prescribers to feel the same way, to feel that it's not only about the pills you're giving to that individual. Again, in that public narrative that's saying this is not a prescribing epidemic, people are saying, well, those pills weren't even prescribed to that person. I don't think that's sufficient anymore. I think we have to feel that responsibility. If they're not part of that person's prescription, if it's another person using them, they're using them because they weren't appropriately disposed of. So there's an opportunity. And I also think it's about, really getting that out there to communities and letting them know that each individual who fills a controlled substance has a responsibility to safely store and use that controlled substance.
Dr. Cooper, go ahead. I'll follow you. I'll follow you.
Sorry, Matt, something else came up. Could you please pose the question one more time? Sorry.
No, not a problem. Just speaking a little bit about drug stewardship and promoting responsibility upon individuals to take it under their own power to rid of unused and unwanted drugs. Just sort of thoughts on that and how do we promote that?
Oh, yeah, sure. Thank you. I think, again, it really just comes down to destigmatizing it, as Dr. Brummett mentioned, and providing education about the fact that this is important, not just for them as a patient, but for their children, their family members, their friends, their community. It's a problem that we all have to target together and not stigmatize it or fear opioids, because they certainly have their place for severe pain, as we know, but that it is something that we just need to tackle together as a community.
And I would conclude by saying that I think the data presented by both Drs. Cooper and Dr. Brummett would indicate that the majority of the medicines that are being abused are coming from families and friends. That's number one. Number two, the clear majority of the people who are suffering from this disorder have never been a patient. So we have to be concerned and continue to work with proper prescribing, work with our doctors as has been indicated, but we also have to put in place strategies to try to keep people from misusing these medicines as well. So it's all of those things that we have to work if we're going to resolve this problem. It's not just a patient-doctor problem. It is the totality of the problem that we have to work. And that's why I think putting in place at the community level strategies to try to keep people from abusing those medicines that have been properly prescribed, but maybe not properly disposed of in the beginning. We have to do that as well as properly disposing of them after they have been prescribed. So it's all those things coming together if we're going to resolve this problem. But clearly, proper disposal is one of the key strategies that we must address.
Wonderful. Well, thank you so much, General Dean, for your remarks, and as well to Drs. Cooper and Brummett. I recognize that we're just a few minutes over the hour now, but appreciate everybody for hanging on the line with us for this really important and robust discussion around safe disposal strategies and the ability to help combat the opioid epidemic across the country. So once again, thank you all for joining us today. It's been a really impactful and enlightening discussion as we look to drive forward actionable and evidence-based change around the epidemic itself. CEPOP looks forward to continuing to engage on these important issues with all of you, and we'll follow up this webinar by posting it to the CEPOP website in the coming days, along with slides as well from today's presentations. A link will be available through next week's CEPOP Weekly Opioid Policy Report, or you can also check back to the CEPOP website beginning later this week. Feel free to reach out to myself as well. We encourage you to share this with your peers and colleagues as just another opportunity to augment the data supporting this as a viable option to help augment our efforts to combat the nation's opioid epidemic and rid households of unused and unwanted prescription drugs, mitigate risks for misuse, abuse, and diversion. And then just sort of a shameless plug for the CEPOP weekly opioid policy report and for CEPOP itself. In the instance you're not on the distribution for that list and wish to, please feel free to reach out to myself. My email is on the WebEx now, provided on the screen. And once again, I just want to take a moment to thank all of our speakers today, General Dean, Drs. Brummett and Cooper, for their important remarks this afternoon, and for all of you for taking the time out of what are likely very busy schedules to learn more about this important public health and patient safety issue. Again, please feel free to reach out with any questions. We look forward to working with all of you in the coming weeks and months. Have a great day, and we'll talk to everybody soon.